Let's pivot to another critical challenge facing our country, the shortage of healthcare workers. With less and less healthcare providers and nurses entering into the space, all of us are suffering from lower healthcare outcomes and higher costs. Nightingale Education Group, led by CEO Mikhail Schneider, is tackling this head-on. And by partnering with VRpatients, what they're doing is incorporating virtual reality-based content to upskill the workforce and help bridge the gap. So please join me in welcoming Mikhail Schneider and Devin Marble with VRpatients.
Thank you, Robin.
Thanks.
Well, hello, everybody. Hey, Mikhail.
Hey.
I just wanted to take a quick moment and move our faces off that screen. I wanted to start by kind of highlighting something that's happening right now today that we might not all be aware of, which is that three legs of a tripod have come together. So in software, we can build software that can do amazing things, but often requires it to be tethered to a very large processor. So you need the hardware to arrive. And that has happened. So we've been building this mixed reality, virtual reality patient care software, and Meta's been building the Quest 3. And when it landed, a whole new world opened up. That was two legs of the tripod. What we really needed was a school who wanted the football, wanted to run with and make a touchdown, wanted to go all in and get something to try. So those three things have happened. And without further ado, I give you. Yep.
The school. All right. Hi, everybody. So one of my favorite quotes is that. And as Robin just mentioned, so in case you don't know, the United States spent $4.9 trillion on healthcare, getting far worse outcomes for that spend than any other developed nation on this earth. And so we spend the most in absolute terms, the most in relative terms. And guess what? The state of the nursing workforce has a lot to do with it. The demographics of it and the sheer numbers of it, right? Which is a problem everywhere, really, but we are winning.
That's right.
Let's talk about that.
Well, this is your favorite quote, right?
It is my favorite quote. I mean, look, those results are by design. Right? They're not by accident. No magic happens to get us to where we are. Now, no magic will happen unless the system itself changes. But this is what we're dealing with today. Yeah, go ahead.
So the World Health Organization is waving a red flag. There's a global shortage coming. You're going to hear the number 2030 a lot today. Because in 2030, we're going to be short 11 million healthcare workers, and 4.5 million of those are nurses. But that 11 million is made up of doctors, patient care technicians, EMTs, paramedics. So that's a global issue. We're included in that global issue.
Yeah, in the U.S., this is this decade, right? The million was projected between 2020 and 2030. We're halfway through it. These retirements are happening because of the demographics of the nursing workforce, and it's contributing to staggering numbers as of today. So let's glance at that. Yep. Today, the very conservative estimates put the shortage as of 2025 at 200,000 RNs in the United States. Today, 200,000 short. Now, the schools cannot handle even a fraction of it. 65,000 applications were turned away.
They're waitlisted. The schools are full.
Exactly.
You can't build enough brick and mortar and enough chairs for the students because they're waiting in line. So you have a global shortage. We've got nurses retiring. We're not even talking about how many of us are going to turn 65 in the next 5 years and need more care. And we all deal with healthcare. We have family that goes into healthcare. It's a part of our life.
I'll give you another stat. The state of California, this is through 2037 now. From 2025 through 2037, the consistent vacancy rate that is projected in nursing jobs is 18%. 18% today through 2037, if nothing in the system.
What do you mean by vacancy rate? Open jobs.
Open jobs.
Anybody want to be a nurse?
Jobs.
There's open jobs.
Yeah.
But there's numerous barriers to access.
There indeed. I started, look, I'm a nurse, and I managed services for a while in the beginning of my career, and then quickly realized that if I wasn't getting what I needed as a manager in services from the educational system, and decided to address these barriers that actually exist out there. Look, the barrier number one, state of California is a prime example, regulatory barrier, right? There's really a big barriers from the regulatory standpoint exist in order to changing the systems.
There's geographic barriers. What is this is an educational desert. What are we looking at for educational deserts?
So educational deserts, this illustrates the most of the United States, the lighter brown color, and this is within 50-mile commuting distance from any one campus. So the lighter ones have one campus, kind of.
That's not a desert. The darker areas, there's 50,000 or more people who have 0 or 1 college.
Within 50 miles.
So you can see where all the schools are, right? And in this darker area, we need nurses. There's no college.
Nothing exists. The Alaska is not on this. The situation there is quite something. So another problem, right, that exists today is that traditional education has not, nursing education specifically, has not really changed in 40 years. Since the 1980s, we've been doing the same thing, fundamentally not evolving anything in the delivery models, fundamentally not evolving anything in a curricular design. And so what happens is we get a bunch of both smart folks that are really, really good at taking standardized tests and passing them, but that's about it. And you put them into the workforce, and they cannot apply the skills that they should have. They cannot apply them. They don't have them. Soft skills, for example. Empathy was mentioned. Not quite there. Problem-solving skills, not quite there. Communication skills, not quite there. They melt down when they get into the workforce. And here's what happens.
Oh, and it's not for a lack of wanting to be a good nurse. Right. I have an anecdote for you. Last week, I met with a staffing agency, and they staff across the United States nurses and travel nurses, and they have a DNR rate. And in the hospital, that's do not resuscitate. But what we're talking about here is do not rehire. So those jobs aren't being resuscitated. Their do not rehire rate is 60 to 70%. That means the nurses that they send to the hospital's like, we don't want them to stay. Send them back. It's not because they don't know how to work in teams. It's not because they're not competent individuals. It's because they're not ready for patient care at that hospital. They don't have the critical thinking skills.
Exactly, the required skills. So this is some of the latest studies. By the way, we have a whole set of
lots of resources.
Yeah. That's we can point you toward. So 50% of new nurses. This is new grads that just get licensed. This is the couple of studies that just came out in the last couple of years. 50% leave their initial employment within 2 years of getting that job. Most of them within the first year, and then. This is the most interesting piece of it, is that 33% of all new grads who started over the past few years, they leave the profession altogether. They encounter the shortage. They encounter the patients that they don't know how to deal with. They don't have the escalation skills, for example. And so they say, you know what? Real estate sounds like a much better option for me.
I wanted to be a nurse. This is what nurses... I'm tired. See you later. Yeah, I quit. We can't have that. They're retiring. We have a shortage. And I know this sounds like a drastic, dire situation, but this is opportunity. This is a spot. This is a sweet spot. The time is now. The train has arrived. All this moment, we've been listening to other people talk about the engagement. People remembering things better. People enjoying their school, their job, their life more when they're doing things in immersive ways. When they're safe and they can do something and really immerse themselves. That applies to healthcare simulation training as well.
Absolutely. And nursing education.
So how do we produce more with an improved or equivalent level of competency? How do we do it faster?
Good question, Devin. How do we do it? Ta-da, drum roll, and for NightinGale. So I asked that question literally 20 years ago. I started in education, and none of it made sense to me. Not who has access to it, not where people have access to it. And so I, convinced an investor to invest into this, and we developed So one-of-a-kind model in the nation where the pre-licensure nursing education is completely distributed, meaning anybody in any community can enroll into pre-licensure nursing programs and become a nurse where they live without, sometimes they'd have to leave home, so the educational delivery model is different. Look at our desert. Yeah, not a desert, but a desert. Even Puerto Rico, not a desert. We are enrolling today learners in all 50 states, District of Columbia, Puerto Rico, growing very rapidly. And
what? 62% of them are below the middle income.
we're making this accessible.
Yes.
This is an important statistic, right? The nursing education became, over the past several decades, it became very, very exclusive and selective, right? You need 4.0 GPAs from really good secondary education in order to get in. This means most people from low income and lower middle income are shut out of the profession completely. They're not given an opportunity to become a nurse.
And you just made me think of something we talked about before, which that it makes sense that you want your nurse of a 4.0, right? You want the best nurse and doctor taking care of you.
Does it make
But
sense,
that's
though?
not what you want. You want the person who made a lot of mistakes when they were learning. So they don't make those mistakes on you and your family. They need a safe place to make mistakes. It's okay if they don't pass with a 99% on their first try. That's not the point. When they get into patient care isn't, what's your name? Brains, I don't know what's wrong with you today, but is it A, B, C, or D? That's not how healthcare works. It's, who are you? Why are you here? How can I take care of you? What's really going on here? And then initiating care. I need to talk to a person, not an exam.
Resiliency is important, and again, people from low income have a lot of it. We are an accredited education institution. We're regionally accredited by NVCCU. Our nursing programs are programmatically accredited, all of them. We have more than 7,000 learners enrolled in practical nursing, associate, bachelor's, master's, so family nurse practitioner, mental health nurse practitioner across the nation. And we do it with a lot of help.
A lot of help. Okay, so we set up the problem, and you can see that the school is working as feverishly as they can on the solution. 7,000 students right now. They're going to launch with VRpatients in May, starting 2,500 students all at once into virtual, immersive virtual reality simulations that their faculty created, not us. And so we know that the schools are full. There's no more seats to put the butts into. I remember once I had a director of simulation college at Pima Community College where I used to work. She goes, how do I improve competency of my students without increasing their butt and seat time because they're full, they're stacked. There's no more hours in the day. And it was distributed digital education. Okay, so according to the NCBSN, which is like the national...
SBM.
What is it?
NCSBM.
It's
National Council.
National Council, State Boards of Nursing. 50% of your simulation time, or of your clinical hours can be replaced by simulation time. But does VR count? It's high fidelity simulation time. So now we have to start getting into definitions. So here's all of your states that are expected to memorize this. But you can see that some states acknowledge that, yes, high fidelity simulation can replace your clinical time, and some states just leave it out. The NCBSN, that body, they don't tell the states what to do. They tell the states what is okay for nursing, and then the states make separate decisions. So what we need is to figure out how can the immersive sim be equivalent to high fidelity simulation. It has to be as realistic as possible. It has to feel as much like real life as possible. It has to remain controlled by the educator so it can meet whatever the local standards are, because every state and every college is different. The answer is yes. It can replace clinical simulation hours. It just varies by state. So this here is a very interesting slide, because over on the left is Sim 1, 1966, and 59 years later, we're still using the same type of simulation. And you'll notice that people are huddled around the mannequin in a group. And the question starts to go, well, why are we simulating in groups? Because Robin, when you become a nurse, because there's some 18% vacancies at the local hospital, you're alone. It's just you and the patients. As a matter of fact, you're going to be outnumbered. It's going to probably be 6 to 8 patients and you. So training this way is a real challenge because it actually doesn't mimic real life, but it's the only way that we have been able to do it. Because you have to group around one mannequin because these mannequins are $100,000 plus each. You can't buy 35 mannequins for 35 students. And then also you can't manage them. Now we need 35 sim operators.
Yeah, it's not scalable at all, right? And another thing about those studies is that all of the studies, about the 50%, have been done on those mannequins. And this is a faculty member that's behind a mannequin or the sim operator, and that talks with the mannequin, and that
They have an iPad. They're adjusting the vital sign.
makes decisions for the mannequin.
If it's working. If it's not working, it's just a CPR mannequin. It's a very expensive one.
Scalability not there.
Yeah, so when you are a college and you've got these mannequins, they're important. You need it tactile. They're important. We have to practice group patient care things for like codes, births, ACLS, like traumas, yes. But the 90% of your patient care time is just you and the patient, right? So you need that one-on-one sim time. And so these guys over here on the left are extremely expensive. But how many mannequins can I fit inside of a headset? How many patient simulations can I fit in a headset? Unlimited. Go to town. All shapes and sizes, different colors, different languages, different accents. And now with Horizon Managed Services, it's, $500 with the device lifetime access. This is what 30 minutes of setup looks like. Or you could do 3 sims in 30 minutes. And there's no setup. And that patient will lay on the bed. And you can engage with the standardized patient as a person who pretends to be a patient or a person. You can engage with people. I can engage with my equipment. I can do tactile skills because I can see.
And when COVID happens?
Tell us how the COVID.
Yeah, when COVID happens, you can be one school in the country that doesn't shut down completely and actually continue delivering engaging education.
That's what happened with NightinGale. So, did you guys know that 40% of a nurse's time when they have a patient, 40% of my time with you, if I'm a nurse, is all communication and medical care time. The rest is I'm going from unit to unit. I'm doing logistics. I'm charting. I'm going to the Pyxis, coming back. I'm grabbing my meds. That's 40% of my simulation time for the last 60 years has been talking to one of these. That's rough. It should feel like this. It should look like this. The students should come out of their simulation with a smile on their face and go, oh man, I just killed that guy. Can I try again? Yes, you can. It was you.
Yeah, me too. Sometimes they try to kill on purpose. But, you're kicked past already.
It's about repetition, but yes. We want you to get good at something. So what does this look like? We have a booth out there. We encourage you to come out and try it. The patient will appear right in front of you in the area. You don't even need to be a healthcare professional. Just talk to the patient, ask them what's wrong with them, and they'll tell you what's wrong with them. And here's a quick video to show you what it looks like in a little short one. Hi, Patricia. I'm going to be your nurse today. How are you?
Honestly, I'm not doing great. I've got this terrible pain in my lower abdomen and back, and it's really frustrating. And it's been getting worse.
Your pulse is a little bit high. Do you have a fever?
Yes, it started last night, and it's been pretty uncomfortable.
Look, a big piece of this puzzle, logistics are a real thing. It's got to be easy for the educator. It's got to work. They can't spend hours setting up all of these headsets. It's got to deploy and be downloadable and ready to rock. That's what Horizon Service as well is to do. It's got to be controlled by the educator, so that way they don't got to worry about what the student sees. They're here to work. They're here to get work done and pretend like it's real work. I'm going to go to the next slide. Is there another?
There you go. So We've been at it for about 5 years in VR space. Again, rolling out next this summer semester. Published 3 papers so far on outcomes in nursing education, and all of those things do improve. And also, so one of the papers actually compares the 2D, same stuff in 2D to the immersive, and the outcomes are way higher in immersive still. So it works, it's available, it's there. Nightingale, even with our, Napoleon plans of world domination, at some point, we cannot get to it all. So if I may call you to action, everybody who's in this room, look, we got to change regulation, right? We have to move away from opinion-based stuff and actually start focusing on what works. So that's number one. Number two, if you're faculty, if you're admins, and you have nursing schools, please start figuring this out. Take it out of the brick and mortar and bring it to where people live. We're one of the largest, if not the largest at this point, nursing education providers in the state of Alaska, the most rural state and the largest state in the U.S. And so if we can do it, you all look, you can do it, and this is available.
One of the true norths of VR patients is that it's a content creation tool. It comes with activities and patients, and you can practice your load sounds, and there's the diabetic patient there ready for you as a template. The goal, though, we train our users to build because it's a drag and drop no-code creation tool. What you create, this is the true north. It's your intellectual property. So what Nightingale is creating, only Nightingale has that library of patients for their students. And it's theirs. It's in their house. That's an important thing because what's in their house meets their curriculum, their standards, how they teach. So Alabama, New York, Texas, it doesn't matter. How you guys want your students to become professionals, we need to be able to give you the tool so the content is yours.
And I would say that at $500 a pop, it is putting 12 sets in a classroom is not the solution, right? It's getting the sets to where people live is the solution.
I want to speak to that actually for a second. So this is a challenge for a lot of colleges. We're using multi-million-dollar simulation centers. That's not going to go away. But the students still need to come into the sim center to do the hands-on tactile skills with the people who are the wise holders of the knowledge with 27 years of nursing experience. This is Joy. She's an emergency nurse with 27 years experience. Don't bring over a rash and ask her what this is.
Yeah.
Okay, so
recommend my services.
it's hard for the brick and mortar schools to wrap their heads around this, but you know what is great for the students is going home or going to the library and practicing on patients and doing sims over and over. So when they come into the sim center to do the hands-on tactile skill, they got better questions, more questions. They've been practicing on that diabetic patient that they're now going to learn on because they just learned about the pancreas yesterday. So we want them to come into class. I was on a flight the other day, or the other week. 2 nurses I was sitting next to by happenstance, they made it through their 4-year nursing call. So in 4 years, and they had a lot of simulations, okay? So this is an engage the audience moment. In 4 years, how many high-fidelity simulations do you think the nurses did in order to complete their degree and get their licensure? Any guesses?
32.
Okay, I got 32. That's a good guess. Right, in 4 years, you think 32 sims, that's definitely doable. What do you got, 5? Oh, he's not very excited, right? They do a little bit more than average. They did 12. Okay, that does not mean they were the team lead. Do you remember those groups I was showing you? You can stand and watch, and that can count. Not because you don't want to get engaged, but because you have to rotate.
Look, untethering, though, is an important piece, right? I understand the buildings, I understand brick and mortar, I understand everybody has invested into things. However, there is no way for us to get to even 200,000 and close that gap without bringing the education to actual communities that need it. But like solving the educational desert, you're not going to put a bunch of campuses in all these rural communities, and yet this education can be delivered there and can be very effective, and people can get licensed and support their communities with their skills.
So come by our booth. We're right over there, and let's talk about why healthcare should train more like the airlines do.
And there's
Oh, there's another. Sorry, Regina. Another slide of sources. Thank you for putting these resources together, Regina. And thank you, everyone, for your attention.
All right, how's everyone feeling? Should we take a quick break or keep rolling? All right.